in which the CT and MRI really helps us. Today we will know the time limits of the CT and when to go for MRI and how to differentiate different types of strokes and how to differentiate abscess from the other ring enhancing lesions, how to differentiate tumors from the huge infracts, when is the contrast needed and when is really the angiogram should be done. And I welcome Dr. Kaushik sir, who is a consultant radiologist in Hyderabad, who completed his MBBS, Diploma in Radiology, DNB. I welcome you, sir. Over to you.
Thank you very much, Dr. Viru. Hi, everyone. I'm Dr. Kaushik. I'm working as a consultant radiologist in Connect Imaging and Diagnostics, Hyderabad.
Hello, I cannot see video, please.
I'm just switching in.
Video on, please.
Okay. Am I audible, madam?
Yeah. Yes, yes.
I cannot see you.
We can see you. We can see you.
Okay. I'm sharing my screen. Yeah. Can you please enable this screen sharing for me? Yeah, thank you. Yeah. Okay. I'm just starting the presentation. Before going into the CT, I just want to show you various densities, what we can see on the CT, ranging from air to the metal. Like if you see here, here is a CT image showing the air density. It will be just similar to that of the surrounding air. Can you see the cursor of mine? So,
yes.
yeah, so this this is the air density. Then comes is the fat, which is similar to the subcutaneous fat of this subgaleal fat. The density is similar to that of the subgaleal fat. And then comes the water density, which is nothing but the CSF. Then comes the white matter. The white matter is usually hypodense. That is, hypo is less dense and hyper is more dense. So the bone is hyperdense and the air is hypodense. So the white matter is usually contains a lot of fat. So it is relatively hypodense when compared to the white matter, the gray matter. Then comes the gray matter. Here, these gyri are the gray matter. And then comes the density blood, which is more dense, and this the blood is less denser than the calcium. There is a bone. And then the highest density is the metal. Usually the metal is more dense, that gives a streak artifact. Then if we go into the anatomy, here is a bone window of the base of skull showing anterior cranial fossa, middle cranial fossa, and the posterior cranial fossa. The anterior cranial fossa usually accommodates the anterior part of the brain, that is the frontal lobes. The middle cranial fossa accommodates the temporal lobes, and the posterior cranial fossa accommodates the cerebellum and the brainstem. And here comes the pituitary fossa, the smaller one, which accommodates the pituitary gland. If we come to the base of the brain, then we have the sinuses. These are the ethmoidal sinuses on the both sides. Posteriorly, the sphenoidal sinuses. And bilaterally, posterolaterally, we find the mastoid air cells. Anteriorly, we have the frontal sinuses. Then we have, if we go into the brain window, the bone window, we have the petrous bones on the either sides, and the tentorium cerebelli and the cerebellum. Then here comes the bilateral tentorium and cerebellum. What is the importance of this tentorium? Why we are speaking here? Because in case of subarachnoid hemorrhage or subdural hemorrhage, this tentorium becomes more dense because of layering of blood along the tentorium. Then in the midline, we'll find a linear hyperdense structure, that is the falx cerebri, which divides both cerebral hemispheres. And if we see in the coronal section, we find this is the falx, and these are the tentorial leaves, and this is the cerebellum. Then we have some important structures here, like this is the anterior interhemispheric fissure, posterior interhemispheric fissure. These are the bilateral lateral ventricles, and this is the Sylvian fissure. The most of the times in the case of subarachnoid hemorrhage due to aneurysmal rupture, we'll find SH in the Sylvian fissures. Then here comes some ventricular system, like this is the lateral ventricles, bilateral foramen of Monro, then third ventricle, and this is the basal cistern or quadrigeminal cistern. Then if you go into the higher sections, we find bilateral bodies of the lateral ventricles and choroid plexus. Usually these choroid plexus show calcifications, which is a normal physiological calcification. Then we can see here frontal lobes, central sulcus, parietal lobe, and occipital lobe. In the lower sections of the brain, we find the brainstem and the bilateral cerebellar hemispheres. Then one more important structure is the insula. Insula is nothing but the insula is nothing but a gray matter lined structure deep to the Sylvian fissure. Here comes the basal ganglia. These are the lentiform nuclei, head of caudate, thalamus. This part in between the head of the caudate and lentiform nucleus is the anterior limb. This is the genu, posterior limb of internal capsule. As we know, basal ganglia is one of the important structure because in case of hypertensive hemorrhages, the most common site of bleed is basal ganglia. Here comes the other sections where we see the anterior limb, posterior limb, and genu. And this is the corpus callosum, genu of corpus callosum. This is the splenium of the corpus callosum. Next, this is the corona radiata, which is the continuation of the internal capsule and external capsule. If we see the mid-sagittal section of the brain, we find this is the tentorium, cerebellum, this is the cerebrum, midbrain, pons, and medulla oblongata. Okay, here we can see some of the vascular territories, that is arterial territories in the brain. This part is circulated by AC anterior cerebral artery. This part is perfused by the middle cerebral artery, and even basal ganglia, that is the anterior part of the thalamus, and the basal ganglia are perfused by middle cerebral artery. The posterior medial aspect or the ventrodorsal aspect of the thalami and occipital lobes are circulated with the posterior cerebral artery. Cerebellum by the vertebral artery. First thing is how to identify a central sulcus. Central sulcus, by these three signs we can identify the central sulcus. One is like in the, if we see central sulcus, we'll have in its mid segment there is a hook-like structure. There is a hook-like bend. Then the central sulcus is a sulcus which can reach up to this falx or in the midline. And then usually we have two gyri, there is a precentral gyrus and the postcentral gyri. Usually the postcentral gyri is less thicker when compared to the precentral gyrus. Then we have the dural sinuses. Usually dural sinuses are paired and unpaired. Unpaired are superior, inferior sagittal sinuses, straight sinus, occipital sinus, and intercavernous sinus. Paired sinuses are transverse sinus, sigmoid sinus, inferior and superior petrosal sinuses, cavernous sinus, sphenoparietal sinus, and basilar venous plexuses. Here we can see this is a superior sagittal sinus and this is an inferior sagittal sinus. Here is a venogram on CT venogram, that is, which is showing superior sagittal sinus, inferior sagittal sinus, internal cerebral vein. This is the internal cerebral vein. This inferior sagittal sinus and the inferior cerebral vein join to form the straight sinus. And the junction between this straight sinus and the bilateral superior straight sinus, sagittal sinus, and transverse sinus is the trochila. Here we can see bilateral transverse sinus right, and this is the left. In this transverse sinus is hypoplastic. Then comes the arteries. This is the MCA, middle cerebral artery, which have 3 segments, that is M1, M2, M3, basically. So the M2 segment is the artery which runs in the sylvian fissure. Then just I want to show you the I want to show you the images of normal brain once. Yeah. So here we can see one case showing a normal brain. I'm scrolling through the images. Okay. Here we can see bilateral cerebellar hemispheres. This is the medulla oblongata. We are going up. We can see bilateral mastoid hair cells. Then comes the pons. This is a pons, which is apple-like structure with the pedicle or the stalk of the apple being the basilar artery here. Then if we go still up, we find the midbrain, which is like a Mickey Mouse. Then on the other sides, if we can appreciate these hyperdense, mild hyperdense structures, these are the tentorial leaves. Then these are the occipital lobes on the other side. And this is the middle cranial fossa showing temporal lobes. Then here comes the middle cerebral artery. This is ICA. Then this is a middle cerebral artery. And we are speaking about insula. So this is a sylvian fissure on either sides. This is a sylvian fissure on either sides. And the cortex underneath is the insular cortex. This is the insular cortex. Why insular cortex is important? Because in case of an hyperacute infarct or an acute infarct, there is loss. We will see insular ribbon sign, which is just broadening of this insular cortex. So then here comes the frontal lobes, bilateral frontal lobes, and we are speaking about the central sulcus. This is the central sulcus what we are speaking about. This is a postcentral gyrus and this is a precentral gyrus. This is the falx in the midline. There are some normal calcifications seen on the brain. One amongst them is the choroid plexus calcifications. Then here comes one calcific focus, which is a normal thing, which is the pineal gland calcification. Then we have falx calcification. This is a falx in the midline. This falx is also showing them calcifications. Then we have dentate nucleus calcifications, which is in the cerebellum on either sides here. Then, so other than that, if we go into the ventricular system here, these are the bilateral lateral ventricles, frontal horns, occipital horns, temporal horns of the lateral ventricles. These lateral ventricles, after the lateral ventricles, here we can see these are the bilateral foramen of Monro opening into third ventricle. This is the third ventricle. Then from the third ventricle, we have this aqueduct. This is a dot we are seeing. This is the aqueduct. If you trace it, it will go into the fourth ventricle. This is the fourth ventricle. From the fourth ventricle, there are two openings on either side. Medially Magendie, laterally Lashka, which by that they will the CSF will be drained into the cisterns, basal cisterns. So then here comes the bone window. This part, what we are seeing now is the atlantoaxial joint. Then we go up. These are the mastoid air cells on either sides. These are the temporomandibular joints on either sides. This is the clivus in the midline. These are the sphenoidal sinuses, maxillary sinuses. Middle, we have, this is a nasal septum, bilateral ethmoidal air cells, frontal air cells. Then on the other sides, we can see in the temporal fossa, these are the zygomatic arches. So any doubts till now in the brain, in the normal anatomy of the brain? If no, I'll go with the next slide.
Continue, sir.
Okay. Then we'll go into the stroke. Stroke usually is like ischemic and hemorrhagic stroke. So most of the stroke, incidence of the stroke is the ischemic stroke, which is 80%, and rest of the things are like hemorrhagic stroke, which is a parenchymal hemorrhage or subarachnoid hemorrhage. Stroke. Stroke is a focal neurological deficit in which there is reduced blood flow and perfusion because of occlusion of a vessel by a thrombus or embolus or hemorrhage. So there are three zones if you see in a stroke. That is an ischemic core, where that is a non-viable part of the stroke, a part of the infarct. And then we have a penumbra, where penumbra is a salvageable part of the infarct, where if we intervene in a correct time, we can save that area. Then the other part is the olgemia, where there is just decreased blood supply. If you see here in the image, this is the ischemic core followed by the penumbra, and surrounding brain is the olgemic area. So what is the role of imaging in stroke? Previously, since decades, we used to use the CT or MRI to differentiate stroke, whether it's an ischemic stroke or a hemorrhagic stroke, because the mode of treatment changes in ischemic and hemorrhagic strokes. So then now with the efficacy of the thrombolytic, so it redefines the neuroimaging. So in the window period, if you are able to bring the patient, if you are able to treat the patient, the stroke, the infarct is treatable. So it is a race against the time. So in the changing trends, we have, first thing is identify the area of infarct, which vascular territory it is, and then at risk area, then cause of the infarct, and predict the outcome. So goals of the imaging is to exclude hemorrhage and assessing alternative diagnosis. And second goal is to identification of the infarct core, penumbra, and olgemic zones. So CT, most commonly performed in the stroke, because it is widely available, it is quick, and early CT is normal in 60% of the patient. It is useful to exclude hemorrhage and other causes of stroke. Not usually, if in early hours, like below 3 hours of a patient with hemiplegia, if the patient is having hemiplegia in last 3 hours, if the CT brain is normal, that doesn't indicate it's normal, because CT is better at picking the hemorrhagic infarcts than an ischemic infarct early. If we take an MRI once the stroke is immediately of the onset or after the onset of the stroke, we can detect the ischemic stroke on MRI. Whereas in CT, it takes at least more than 3 hours. We have different types of stroke. There is hyperacute, acute, early subacute, late subacute, and chronic, depending upon the duration of onset. Like within, if it is within 6 hours, it is hyperacute. 6 to 24 hours, it is acute. And 1 to 3 days, it is early subacute. 4 to 7 days, it is late subacute. And more than 7 days is the chronic. So we have to, the salvageable part of the stroke is the hyperacute stroke. If we can identify a patient with hyperacute stroke, then if early intervention was done, then the tissue is salvageable. So what are the findings? Early CT is usually normal, or else we can find some ischemic signs. Like what you have is a dense MCA sign, disappearance of basal ganglia sign, and loss of insular ribbon sign. So here comes the importance of the insula. So if we see, this is the hyperacute infarct. We have dense, hyperdense artery, that is a hyperdense MCA sign. Here is a M1 segment of MCA, which is hyperdense, which indicates if there is a unilaterally hyperdense MCA, that indicates the patient is having an hyperacute infarct. Then here comes the loss of insular ribbon. If you see, this is the insular ribbon on the left side, which is normal. If you see on the right side, that ribbon is lost. This is the insular ribbon. This ribbon-like sign is lost. It's all thickened because of cytotoxic edema. So then other sign is disappearing basal ganglia. If we see here on the right side, the basal ganglia is clearly seen, like with the internal capsule, head of the caudate, and the lentiform nucleus. But on the left side, that is not well differentiated, or it is called disappearing basal ganglia sign. So if we have one of these 3 signs, or all the 3 signs, that indicates, even if one of the sign is there, that indicates a hyperacute infarct. Then we have the acute infarct. In acute infarct, we can see this is acute infarct. So in acute infarct, we have an hypodense area, which shows some mass effect. Like here, on the left side, the frontal horn of the lateral ventricle is normally visualized. On the right side is compressed because of the mass effect. And usually these acute infarcts are wedge shaped. Here we can see it is well marginated and is like a wedge. Then comes the subacute infarct. So as the infarct ages, it will become more hypodense. So the subacute infarct is more hypodense and the mass effect persists. And second thing, in subacute infarct, we can find hemorrhagic transformation. Previously appearing acute infarct, if we see in the follow-up CT, if we are finding some hyperdense serpiginous structures within the infarct, that indicates an hemorrhagic transformation. So here we can see hemorrhagic transformation. Here is a hypodense area, which is a subacute infarct, in which we find hemorrhagic transformation. This is the hemorrhages. So here comes some tricky situation where we have to differentiate a subacute infarct from a hemorrhagic infarct or a parenchymal hemorrhage. So usually hemorrhagic transformation, the hemorrhage will be seen along the sulcal spaces. Whereas in a parenchymal hemorrhage, the hemorrhagic component is a predominant thing, which is surrounded by a vasogenic edema. Then comes the chronic infarct. Here is the infarct. That is a gliosis. If you see a chronic infarct, the density of a chronic infarct is similar to that of the CSF here. Gliosis is similar. Gliosis, the density will be similar to the. Then, to know the cause of infarct, what we do is the angiography. So on CT angiogram, here we can see this. Here we see a dense MCA sign on the left side. Okay, and we have done in CT angio. In the CT angio, that segment is not picked up. That segment of the MCA shows no filling, which means that is thrombosed. Here is the dense MCA sign. The same segment is showing lack of filling, which is the thrombosed part. Why do you have that dense MCA sign? Because we have an hyperacute or acute thrombus in the vessel, which gives an increased density. Then on CT or other imaging, we can predict the complications of the infarct. If we have a large cerebral infarct, there is 95% of chance of hemorrhagic transformation. Then we have gray matter infarction. That if in the infarct the gray matter is more involved, then there is high risk of hemorrhage. Then we have this poor collateral flow. If there is no surrounding blood vessels supplying the infarct in the angio, then that is high risk of having non-salvageability. This is regarding the hemorrhagic. Till now we have spoke regarding the arterial infarcts. There is other thing called as venous strokes, where we have venous strokes are doesn't confine them to the arterial territory. First thing. Second thing, venous strokes are usually peripheral, usually multiple, patchy. They are not wedge shaped, and they are seen predominantly in the white matter. Whereas if we see an arterial territory infarct and an arterial infarct, they predominantly involve the gray matter, gray and white matter. Whereas in venous infarcts, if you say venous infarct is usually hemorrhagic infarct. Venous infarct usually peripheral, multiple, and they do not follow any arterial territory. Other than that, some supporting signs are like dense clot sign, empty delta sign, and loss of normal flow void on MRI. Here comes a dense clot sign. That is, if you see, this is the posterior aspect of the superior sagittal sinus on a normal CT brain, showing a dense clot sign. This is a dense clot sign. Then here comes, this is a contrast image. In the same dense clot sign, if we give contrast, that will be appeared as empty delta sign, because this thrombus within the sinus will not uptake that contrast. Only the peripheral area of the patent venous sinus is seen, and this is the thrombosed part. And here we can see an hemorrhagic infarct. Here we can see a hemorrhagic infarct. Okay. If we find a parenchymal hemorrhage which is peripherally placed and either a dense clot sign or an empty delta sign on contrast, that indicates a venous sinus thrombosis and a venous infarct. These are some MRI images. This is a venogram showing thrombosis of left transverse and sigmoid sinuses. They are not seen. Usually in case of thrombosis, the venous in the MR venogram, we don't see them because there is no uptake of flow. Then we have the hemorrhagic stroke. In this hemorrhagic stroke, if you see, the basal ganglia is the most common structure to be involved in the hypertensive hemorrhages. So we can see this hyperdense area in the basal ganglia, followed by hypodense peripheral edema. This hypodensity is the edema. This central hyperdensity is the hemorrhage. So CT is the best modality to see hemorrhages, because what happens in MRI, we have SWI sequence where we can see hemorrhage. So in SWI, the calcium calcifications, hemorrhage. All these things will appear in similar signal intensity. So CT is best to pick up the hemorrhage. Here we can see stack of images showing a venous infarct in the right temporal lobe. Why I'm saying venous infarct? Because we have multiple hemorrhagic areas and there is a hypodensity sitting. And then we have an hyperdense right transverse sinus here, which is marked by these arrows. Hyperdense right transverse sinus, which is a thrombosed right transverse sinus. Here we can see stack of images. This is a hemorrhagic infarct, and this is the thrombosed right transverse sinus. Next comes, if you see hemorrhages, usually broadly we can see like a subarachnoid hemorrhage, which is commonly seen in the case of aneurysmal rupture or a trauma. Then we have the basal ganglia in case of hypertension or lobar hemorrhage. It's like lobar hemorrhages are usually seen in the case of venous infarct, a tumor bleed, or vascular malformation, or in the case of cerebral amyloid angiopathy. These are the common conditions where we see day-to-day hemorrhages in the brain. Like first thing is the subarachnoid, which is the most common cause is aneurysmal rupture. Basal ganglia because of hypertension. Lobar bleed, any lobe, involvement of any lobe because of cerebral amyloid angiopathy or venous infarct or tumor or vascular malformation. Here we see subarachnoid hemorrhage seen in the predominantly situated in the sylvian fissure. Okay, these are the bilateral sylvian fissures. These are the cerebral sulcal spaces. This is diffuse cerebral edema is there, and a lot of SH. Most of the cases with this picture, we have an aneurysmal rupture, and the most common ruptured aneurysm giving this picture is ACOM aneurysm. Then comes the basal ganglia. Here we can see this is a CT image showing an acute parenchymal hemorrhage in the right basal ganglia. This is an acute thing. Over a period of weeks and months, the acute hemorrhage will become a chronic one, leaving a scar or gliosis. This is the gliotic region in the right basal ganglia secondary to hemorrhage. Then comes lobar hemorrhages. Here we can see these are the lobar hemorrhages. They're seen involving the lobes. They are not seen in the basal ganglia. They're not seen intraventricularly. Okay, they're seen confined to the lobes. Here we can see this is in the frontal lobe. Here it is in the occipital and temporal lobes. So other forms of hemorrhages, so what we can see are like here is an EDH. Why I'm saying EDH, extradural hemorrhage, because it's a setting of trauma, first thing. Second thing, it is a biconvex structure. It is a biconvex hyperdense structure. EDH is biconvex, and this is the subdural hemorrhage, which is convexo-concave. This is a convex and this is a concave part. So convexo-concave. I usually used to have the doubt like why EDH is biconvex and why subdural hemorrhage is convexo-concave. Later on, I found out it's like EDH is an arterial bleed. So arterial bleed usually has a high pressure thing, so it will create a mass effect and give a convex structure like this. And in case of subdural hemorrhage, it is convexo-concave because it is a venous bleed. It cannot push the brain parenchyma that much to give a convex contour. So here this is an extradural hemorrhage and this is a subdural hemorrhage. And here comes the intraventricular hemorrhage. Here we see bilateral lateral ventricles are filled with acute hemorrhage. This is a hemorrhage in the basal ganglia. Previously also we've seen. commonly seen in case of hypertensive crisis. And here we see an hemorrhage in the posterior fossa, that is in the right half of the cerebellum, and also extending into the fourth ventricle. So I want to show here is a case of trauma where we see there is a soft tissue swelling in the left parietal region, but the patient is having parenchymal contusions. Here, these are the parenchymal contusions, some amount of subarachnoid hemorrhage, some amount of subdural hemorrhage here. So the trauma is on the left occipitoparietal region, but the parenchymal hemorrhages are seen in the right frontal and parietal lobes. This phenomenon is called countercoup injury because of an impact on this side, there is the brain parenchyma goes and hits to the calvarium on the opposite side, giving hemorrhagic contusions. This is called countercoup injury. Usually we may not find any fractures in this area, only it is an countercoup injury. Then here we see some of the times we see a hypodense is like near to CSF like attenuation, fluid like density in the subdural space. So this is like a chronic subdural hemorrhage. Then we'll go into other pathologies. Any doubts still now?
Questions in the last session.
Okay, done. So some other basic pathologies, if you see, like day in and day out, we see calcified granulomas. So here comes here are the two things most commonly seen. The upper one is neurocysticercosis and lower one is tuberculomas. So how am I saying it is neurocysticercosis and tuberculomas? Even in MRI, if we do, it is very difficult to differentiate a neurocysticercosis from tuberculoma if they are solitary lesions, one thing, or if the lesions are less than 3 or 4 in number. So if we work, if to differentiate tuberculoma for NCC, we need to do a lot of other sequences in MRI like magnetization transfer and spectroscopy. But in these images, we can straight away say the upper part is the neurocysticercosis and the lower part is the tuberculoma, because usually NCC has different phases, like we have colloid granular, vesicular phase, and calcified nodular phase. So in the case of vesicular phase, we'll find an NCC like this, hypodense area with a small hyperdense dot. So this hyperdense dot is nothing but a scolex. A hypodense area with an hyperdense area with a hyperdense dot, we can say it is as an NCC. This is a plain image. If we give contrast, we find ring enhancing lesions. These are the multiple ring enhancing lesions, and we find this central dot is enhancing and the peripheral wall of the cyst is enhancing. So this is in the case of NCC. And here comes the tuberculomas. We don't find in tuberculomas a central dot, first thing. In tuberculoma also we have different phases, like we can have a normal granuloma, then it will calcify, and inactive granuloma. In the active phase of neurocysticercosis or tuberculoma, we'll find that peripheral edema and ring enhancement. Inactive lesions usually do not show any peripheral ring enhancement and surrounding edema. So tuberculoma, if you see here, these lesions are of varying sizes, and usually most of the cases, the tuberculoma, we have conglomerate lesions, like 1 and 2 or 3 lesions will form an irregular bizarre lesions, and will have adjacent cerebral edema. It is like other signs where we can say this is an NCC and not tuberculoma is if we are able to find similar lesions in the adjacent scalp or in the covered the section, soft tissues of the neck, upper neck. So we can straight away say it is a neurocysticercosis. Then here comes another ring enhancing lesion. This is a ring enhancing lesion in the left frontal lobe with diffuse adjacent vasogenic edema. This is causing a lot of mass effect and a mild midline shift towards the right side. So this is this has a lot of DDs, but this is a classic appearance of a cerebral abscess. Usually, in case of cerebral abscess or any infective lesion, the edema is more than, or it is more, the vasogenic edema is more than the lesion. The lesion will be of some significant size, and the edema is more than the lesion, what we expect. So here I show you another CT. So still till now, I think I have explained you ischemic stroke, various types of parenchymal hemorrhages. What are the different types of parenchymal hemorrhages, like intraventricular, lobar, and subarachnoid hemorrhage? And other than that, in trauma, what we regularly see, like SAH, subarachnoid hemorrhage, subdural hemorrhage, and extradural hemorrhages, parenchymal contusions. So if we see a lesion like this now coming up, we have a hypodense lesion. We have some fat density here, fat density lesion. We have one calcification. So a lesion on a plain CT, if it has a varying densities, then we should suspect some tumor. So here, this is the case of a GBM, glioblastoma multiforme, which is a high-grade glioma, which shows varying densities. All this glioblastoma multiforme shows hemorrhage, some amount of fat density, some amount of calcifications. So here is a case of a tumor. Then this is another bizarre-looking tumor, a lesion. Sorry. So here we see a lot of hyperdense serpiginous structures. This hyperdense structure, if you see, we have some confusion, right? We'll get a CT film where we see an hyperdense structure. We have to differentiate now, that is from that whether it is a calcification or a hemorrhage. So if some hyperdensity is very similar to that of the calvarium, then it is a calcification. Here we have a lot of calcifications, parenchymal calcifications in the frontal lobe. It is a case of an oligodendroglioma. So there is a tumor. So why I'm saying, basically what we need to differentiate is whether it is an hemorrhage, whether that is an hemorrhage or infarct with hemorrhagic transformation, or a tumor bleed, or a, what do you say, calcification in the tumor. Here comes a case of multiple. If you see multiple lesions like this, more than 1 or 2 lesions with adjacent perifocal hypodense edema. If you give contrast, these structures are enhancing. This is a case of metastasis. Metastasis usually, not a rule, but usually they are multiple. And some of the metastasis, usually they are seen in the gray-white matter junctions. If you see here, this is the gray-white matter junction. So this is the gray-white matter junction. So usually metastasis is seen in the gray-white matter junction. They have perifocal edema. They enhance on post-contrast images, and we need to see the other history and other workup to find the primary. Most common brain tumor in adult is metastasis. Then if you see here, various, I have put a slide here showing different types of hemorrhages. So if you see here, this is a lobar hemorrhage, where this is a case of cerebral amyloid angiopathy. Then here comes the tumor. This is a tumor bleed. Most of the cases, it is like, it will be challenging to say whether it is a tumor bleed or just a parenchymal bleed on plain images. We need contrast. We need to work up with MRI. Because why MRI is to differentiate whether the MRI has a better soft tissue resolution and soft tissue differentiation. So, and here is a case of metastasis. This is a solitary metastasis seen in the gray-white matter junction. If you see, all of these look similar, but we have to have other signs and other clinical history to come to a diagnosis. It's a lobar bleed, that is clear, right? And here comes the tumor bleed and is a venous infarct. There is some similarity between the tumor bleed, venous infarct, and hemorrhage with infarct with hemorrhagic transformation. Because in this place, there comes the role of contrast, where if we have a clear-cut history of a patient having an acute hypertensive crisis and we see a parenchymal hemorrhage in the common location, basal ganglia, so we can directly say it is a hemorrhagic hypertension. Because of hypertension, we got a hemorrhage. If we have loss of altered sensorium with vague, like only just symptoms of headache and any other primary elsewhere, then the first possibility of metastasis comes. And in case of venous infarct, we will definitely see other signs like empty delta sign and dense clot sign in the venous sinuses. And here comes the hemorrhagic infarct. Hemorrhagic infarct, if it is confined to the arterial territory and if we have the previous images like follow-up images, we can come to a diagnosis of an acute hemorrhagic infarct. Next, if you see this is also a lobar hemorrhage seen in the case of AVM, arteriovenous malformation. If we have a lobar infarct, we have to go for a contrast study. If we have a subarachnoid hemorrhage, if it is a non-traumatic subarachnoid hemorrhage, then we have to go for contrast study, that is angio. In case of venous infarct, we have to do a contrast study, that is a contrast CT venogram. So these are the cases where when we suspect a venous infarct, an AVM, or a tumor, metastasis, or any venous malformation, we do a contrast study. This is the presentation. Any doubts? Any questions?
Thank you very much, Kaushik sir. Very good presentation. And first, I welcome Dr. Srinivas sir to give your views and inputs, and then next we will take the questions. Dr. Srinivas sir, President of ARPI, I welcome you, sir.
Hello, am I audible?
Yes, sir.
Am I audible?
Yes, sir.
Yes, sir, you're audible.
Good evening, everybody. Thank you, Virup and Kaushik, for the lucid talk. And thank you for giving me this opportunity. Dr. Kaushik has elaborated very well about especially about the stroke, how to differentiate between the ischemic stroke and hemorrhagic stroke. And along with this aspect, the injuries, the tumors, the metastasis, what are the characteristic features on the CT brain. He has very well elaborated on all these things. As you all know, computer tomography, otherwise CT, has revolutionized the radiology. Not only the radiology, but the entire medical field. Medicine as a whole has been revolutionized by the computer tomography. It has made the healthcare, it has increased the quality of the healthcare. It has increased the quality of the healthcare. And moreover, it became safer also. Healthcare became safer by means of least invasive mode of investigation. As technology has improved, more and more advances has come, and the image quality has also improved. Then now the CT became a vital part of the diagnostic process. This is all we are seeing in our day-to-day practice in the outpatient settings. We are normally we encounter with minimal head injury. In our primary case settings, most of the cases we see the minimal head injuries. How to evaluate these things? These are very important. And at the same time, stroke also, and chronic headaches. Such common complaints are very common in our primary care setting. We should be able to evaluate and evaluate. Dr. Kaushik has clearly told when the most important, one of the most important thing in a primary care setting is when is the indication of the CT brain? Because for every case, for every minimal injury case, we are not supposed to suggest a CT brain. We should apply the principle of judicious imaging, what we call. There is certain criteria is there. The appropriate criteria we should follow. For certain clinical scenario or for certain clinical presentation, a certain diagnostic modality will be there. So we should know for which complaint, for which clinical scenario, what is the apt mode of investigation, what is the apt modality of radiological investigation. That you should know, that what we call the principle of judicious imaging or appropriateness criteria. Suppose in the minimal head injury, what we have seen, generally what are the features? The headache, vomiting, drug intoxication or alcohol, age more than 60 years, and the short-term memory loss. These are some features will be there. If there is a criteria, there is criteria that if one or more criteria are present, CT brain is indicated. So for everything, for stroke or for other deficits, generally if there is a focal neurological deficit is there, definitely CT brain is indicated. But for small injuries, if the GCS is normal, there is no history of vomiting, there is no history of headache, there is no history of seizures, then CT brain is not indicated, because every investigation has its own advantages and disadvantages. There is a risk of radiation exposure. So we should, at the primary care setting, we should be cautious not to write or not to suggest for every case CT brain. That will be possible only we come to know about the criteria. So our primary care, especially the primary care physicians, we should be thorough with the taking history and the clinical examination, followed with the advanced mode of investigations. Then only the cost effectiveness of such a vital investigation, CT brain, we can achieve that cost effectiveness. We can decrease the burden of the disease, in the emergency department, because most of the family physicians, we work in the outpatient care settings and we work in the emergency care settings, where we have to differentiate whether the CT is indicated or not. So if we are very cautious, if we are thorough with the criteria, if we apply the principle of judicious imaging, then we can lessen the burden of and we can reduce the number of the CT scans, we can reduce the risk of radiation, all these things. So that in addition to what Dr. Kaushik has told, I think this aspect is also very important, and we family physicians, we should keep in mind, especially this principle of judicious imaging. Thank you very much, Dr. Kaushik, for your lucid presentation, very excellent presentation. All our doctors are very much benefited by your presentation. A really wonderful session. Thank you, Greep, and thank you, Jyotika, and all the Spice Route doctors who are conducting regular academic sessions. Thank you very much, doctors.
Thank you, sir.
Thank you very much, sir. Thank you for your inputs. And questions, please. Any questions? Kaushik sir, one of the question is asked.
Yeah. Okay.
Can you indications and contraindications for the contrast studies in CT brain?
Okay. You usually like indications of contrast is like if you want to evaluate a venous infarct. Just now I have told that if you want to evaluate a venous infarct, we want to see the empty delta sign, that is thrombosed superior sagittal sinus or transverse sinus. Then we do a CT venogram. That is one of the indication. Second indication is like if we suspect a brain tumor, if we suspect a metastasis, then that is an indication for contrast again. And third thing, in a case of SH where we suspect an aneurysmal rupture, that is an indication for contrast. And then we have an AV malformation or any vascular malformation in the brain, then that is an indication for contrast. Then other thing is like in case of acute infarct, if you want to find out the cause, if you want to see for the arterial thrombosis, in case of MCA thrombosis or posterior circulation thrombosis, we do a CT contrast angiogram. So these are the basic indication. And next is like we have seen like to differentiate between various ring enhancing lesions. First of all these ring enhancing lesions require contrast. Like these ring enhancing lesions are usually 5 things, that is calcified granulomas, cerebral abscess, then we have is metastasis, then we have is demyelinating plaques. These are the usual indications for contrast. That is the thing. And next thing is like contraindications. If we specifically see is like drug allergy. First thing, if the patient has previous allergy to the contrast, because it is iodinated contrast, but this allergy to contrast was there previously because we used to use high osmolar contrast medium. Now we are using low osmolar and iso-osmolar contrast, which is having a similar osmolarity to the blood. So still few people are allergic to iodine. If patient is allergic to iodine, then we don't advise contrast. First thing, in case of low cardiac output, very low cardiac output, that is also one relative contraindication to the contrast. First major contraindication is like low GFR, high serum creatinine. So low GFR is a contraindication for contrast because kidneys are the route of excretion for the contrast. So major contraindication is renal failure or high creatinine, and relative contraindication is like allergic to iodine, allergic to contrast media, and then other contraindications just we spoke. Like low cardiac output, and even in case of hypertensive emergencies or hypertensive crisis, the patient is in hypertensive crisis, that is also a relative contraindication for the contrast. So then any next question?
Next, someone asked the role of CT in concussion.
Okay, so role of CT in concussion. So we have usually we have some presentation like patient had a head injury and CT is normal. CT is relatively normal, but patient has a very low GCS. So here comes the thing like to rule out diffuse axonal injury. So some of the times in the CT we can see very tiny punctate hemorrhagic foci, which usually we feel that images are relatively normal, but the patient condition is poor. So in that condition, there is a condition called diffuse axonal injury. When there we have shear force, multiple tiny punctate hemorrhages in the gray white matter junctions. So usually we see in the gravate matter junctions, corpus callosum, posterior fossa. So the most apt investigation of choice in the case of diffuse axonal injury is MRI brain, where in HWA sequences we can see multiple tiny punctate hemorrhages. Any question other than that?
Hyperacute, in fact, you said less than 3 hours, CT is not so reliable. In peripheral areas where MRI is not available, what are the signs we can go with?
In hyperacute, that's what we have. This 3 signs. What is like loss of insular ribbon sign. Then what we have is basal ganglia, invisible basal ganglia sign, and dense MCA sign. Most commonly, what we see is a dense MCA sign, like what we have seen in this previous slide. I'm going to that again. Yeah, these are the 3 signs what we commonly see in hyperacute infarct. Dense MCA sign or dense artery sign, loss of insular ribbon. If we compare on the opposite side, this is the insular ribbon. Insular cortex is the cortex which is situated deep beneath the sylvian fissure. This is the sylvian fissure. This is the insular cortex. Here we can see loss of insular ribbon sign and disappearing basal ganglia sign. Any other questions?
Any role of CT in chronic unexplained headaches, or it is best to go for MRI in those cases?
In acute headaches, I say, because in acute headaches, what we see is usually some of the patients, even in the young patients, we find some lobar hemorrhages, where we find out no reason, but we find suddenly if patient presents with a sudden onset of severe headache, possibility of an hemorrhage in the parenchymal hemorrhage is one of the possibility. And in case of chronic, if you say, it is like even if you do an MRI or the CT, in chronic situations, the diagnosis will be the same. Most common thing, cause of the headache, it is idiopathic, and second thing is sinusitis. Migraine, we find no signs as such an imaging. It's like slow SOLs also can cause some sort of headache. So in headaches, CT acts like a screening, but only thing why people routinely don't advise CT because it involves radiation. MRI has no radiation, so patient can get it done. But CT, there is involvement of radiation, so that is the only thing.
Any role of normal CT or CECT for meningitis?
Yeah. So it's like in any case of meningitis, first investigation of choice is MRI contrast. Second comes the contrast CT. So in contrast CT, what we can differentiate is like whether it is a tuberculous meningitis or non-tuberculous meningitis. We'll find in tuberculous meningitis, what we have is basal exudates. In the basal systems, we'll find multiple hyperdense areas and also thick nodular enhancement on post-contrast. Whereas in case of normal bacterial or normal viral or bacterial meningitis, we have smooth meningeal enhancement, the smooth meningeal enhancement. Usually CT contrast will give the answer, but the investigation of choice is MRI with contrast.
And next one is if we suspect a patient with brainstem MRI clinically, it's better go for CT or MRI.
I didn't get it. Brainstem infarct or
brainstem pathology.
Okay. It's like two things. If we are suspecting a brainstem mass or a brainstem infarct, what happens in CT? We have this bone hardening artifact. Because in the posterior coronal fossa, just a minute, I'll just open that. Yeah. If you see here, this is the brainstem here. The brainstem will not be clearly seen even if we have a 128 slice CT also, because it is surrounded by this nearby bones. So because of these bones, we have bone hardening artifact. If you see, we are having some hypodense areas here in these pons. We may confuse whether it is an infarct or any other lesion, any demyelinating lesion. But the thing is, it's normal. For any posterior fossa, especially brainstem, MRI is the investigational choice, because in CT we'll have this bone hardening artifact because of the adjacent dense bone. And also the upper part of the spinal cord also, we cannot clearly see them on the CT. If you are able to, if you are talking about a lesion, mass, then okay, we can find out whether there is a mass or not on CT, but not infarct. Infarct, with 100% confidence, we can say only an MRI if it is a brainstem.
Once again, can you please show us the difference between hemorrhagic transformation versus hemorrhage?
Okay. The screen is seen, right? Okay.
Yes, we can see.
This is a venous infarct, which is a hemorrhagic infarct. Peripheral, irregular, adjacent edema, and there is also loss of this delta sign, empty delta sign. And plain CT will have this hyperdense clot sign, the superior sagittal sinus. Then here comes, I'll show you. Yeah. Here, if you see, this is a venous infarct and there is a thrombosis. Here is an hemorrhagic infarct, which is confined to the, hemorrhagic infarct, which is confined to the arterial territory. We don't find any empty delta sign or signs of venous sinus thrombosis. And here, this is a lobar hemorrhage. This is also a lobar hemorrhage. And these are the metastases. Metastasis usually multiple, usually in the gray-white matter junction. Metastasis also usually will have hemorrhagic and non-hemorrhagic metastasis. Like hypervascular metastasis, we have hemorrhagic metastasis like melanomas, thyroid, renal cell, where we have hemorrhagic metastasis. If we have a lobar hemorrhage and we don't have any signs of pathology, what is the cause of the lobar hemorrhage? Whether it's an AVM or it's a cerebral amyloid angiopathy, or whether it is venous, then next step is to do a contrast. We'll have some answer.
The trending question: CT findings of COVID.
Okay, you want to HRCT findings?
CT findings in a COVID patient with neuro manifestation. Any specific CT findings?
It's like not specific CT findings. Like in COVID, brain involvement is like most commonly what we have seen is venous infarcts and venous sinus thrombosis in this COVID scenario. We had a lot of CSVT cases where in COVID we are finding venous sinus, superior sagittal sinus thrombosis, transverse sinus thrombosis. That is one thing. Second thing is osteonecrosis and fungal osteomyelitis, mucormycosis was seen in case of a patient complained with headache in the maxillary region and frontal region, and CTs found fungal osteomyelitis. That is the second thing. Rather than venous sinus thrombosis, studies say there are even parenchymal hemorrhages, but not that common. I thought you were asking HRCT findings, so that I am getting prepared to bring other slide. Okay. Yeah.
And one of the doctor want to know about screening MRI for brainstem. What all we can do comparing to the MRI full study?
Okay. What about screening MRI for brainstem to make
Can
out?
make out. Can make out.
Okay. How do we make out from screening MRI compared to full study? Okay. Actually, in any MRI, we usually cover till the we'll cover the brainstem. First thing. Second thing, what we have is separate sequence for the posterior cranial fossa, that is CIS sequence in the MRI, where that is usually for these vascular loops and the cranial nerves. For the study of the cranial nerves which are arising from the brainstem, from the if you start from the third cranial nerve to the 12th cranial nerve, all these cranial nerves can be seen from the origin, how they're originating from the brainstem. First thing. Usually, this is advised in case of unexplained vertigos, unexplained tinnitus, and sudden onset of any facial palsy, sudden onset of trigeminal neuralgia-like pain, where we have some vascular loops abutting these cranial nerves. This pulsatility of these vascular loops causing some neurological deficits in the adjacent cranial nerve. Usually we do that posterior fossa study for these cranial nerve study and vascular loops.
Thank you.
In routine advised MRI brains, we don't do that posterior fossa sequences as such, because it itself takes some 8 to 9 minutes of time for only that sequence.
Any other questions, doctors? Yeah, no more questions. Thank you very much, Kaushik sir.
Thank you very much, Viceroy India, for giving me this opportunity. Virup, sir, thank you. Thank you one and all for attending patiently, sitting for more than 1 hour with me.
That's a very concise, to the point, and very informative session, sir, for the primary care physicians who are practicing in the peripheral areas where CT is only the thing. Thank you very much for that. Thank you, sir. Yeah. Thank you all for attending the session. Thank you, Srinivas sir. Thank you, Serin sir. Thank you, Jyotika ma'am. Thank you, Kailash sir. Thank you, one and all.
Thank you, Dr. Virup. Thank you, Dr. Kaushik.